Good morning and good evening. We'll just let people join and we'll start in 1 minute. So good morning and good evening to everyone, our friends and community online. Thank you so much for joining us for our Global Tracheostomy third webinar of 2024. I'm Dr. Amy Freeman-Sanderson, and I'm delighted to be joined by Dr. Michael Brenner, who is the president of our GTC. So welcome everyone. Today, our topic is navigating the journey with tracheostomy, transitions through childhood and beyond. I would like to extend my thanks to our generous sponsors, so Medtronic, ATOS and ICU Medical, who help us provide educational webinar and meeting our GTC goals of optimizing care for people with tracheostomy. I would like to acknowledge the country that I'm on. So I'm on Gadigal land in Sydney, Australia. So I would like to pay my respects to the traditional custodians of knowledge for the land in which we meet today. And there are many lands, so feel free to pop into the chat where you're joining us from. And I'd like to extend my respects to the elders, past, present, and emerging, acknowledging them as traditional custodians for knowledge of this land. So today, in terms of our webinar, we have a couple of objectives that we're going to cover with our wonderful panel of speakers. So firstly, to understand early transitions for children with a tracheostomy as they move from ICU to the wards and then to their journey home. To identify family and community supports to optimise care for children with a tracheostomy. To understand the physical and emotional needs of patients and family members across phases of transition, so across different stages of childhood, teenagehood, and then into adulthood, and really getting those personal insights through stories that the panel will share with you today. And lastly, to discuss opportunities and priorities for us to optimise safe tracheostomy care. So we're really looking forward to hearing from our panelists and ideas from the audience. So we do have a wonderful webinar panel and Dr. Michael Brenner is going to give a longer bio, but we do have Sandy Foster, Tracey Hurlbut, Stephanie Pratt and Lou Vaudour-Marty. So thank you very much to the panelists and I'll hand over to Michael.
All right, well, thank you all for joining this session. It's really wonderful to see everyone here and we have a wonderful presentation for you. Our first speaker is Sandy Foster. She's a clinical nurse consultant who's worked for Monash Health for the past 25 years. She's previously worked at West Gippsland Hospital in Victoria, Australia, and Great Ormond Street Hospital in London. At Monash, she's initially worked on acute pediatric medical oncology wards, and since 2005 with Monash Children's at Home on their complex care team. Her role provides and improves service provision for children with complex medical needs and their families inside and outside the hospital. Her role promotes continuity of care by actively facilitating and coordinating care beyond the walls of the hospital. So this includes assisting with training of parents and staff to safely care for these complex children so that they can be discharged and cared for in the community, attend schools, and have more normal lives. In recent years, Sandy has developed a special interest in children with tracheostomies, and she provides support in both the community and hospital. She currently has a focus of improving standards of care and patient outcomes for this very vulnerable cohort. So it's a delight to hear her presentation, and I'll hand it over to you now, Sandy.
Great, thank you so much for that. Good morning and good afternoon to everybody. So today I'm going to talk about little M's journey from transition from hospital to home. So just a little bit about her diagnosis. So she was diagnosed at 2 months of age from another hospital in the setting of worsening progressive stridor at rest with associated desaturation. She underwent several investigations which demonstrated bilateral vocal cord palsy, and this obviously required her to have a tracheostomy. There were nil other comorbidities, and her MRI was NAD. So we met with the family to explain the results of these investigations and the need for the tracheostomy. This family was from a non-English speaking background. It was really difficult to find an interpreter for her particular dialect. Fortunately, we were able to have her cousin to assist with interpretation. And Mum was able to speak conversational English, but Dad very minimal. So we discussed with the parents why she needed the tracheostomy in order to keep her airway safe. We described the clinical course that we expected and the training and education required. And we likely thought that she would be in PICU for 2 weeks and then transferred to the ward with ongoing education and support. So prior to the insertion of the tracheostomy, we met with the parents and we explained what a tracheostomy is, and we showed the parents what it looks like in the use of an educational doll. And we also at this stage had ENT consult with interpreter to consent to this procedure. So through the initial tracheostomy insertion phase, she spent the first 7 days in PICU, and at this stage, parents were only watching nursing staff how to manage the tube. The education for this family was delayed due to her respiratory illness that she had at that stage. On day 8 of the tracheostomy tube insertion, we had a MDT meeting and we discussed the education plan, and we thought she'd be discharged home in approximately 4 weeks' time. At this stage at Monash, we changed the bed card from ENT to respiratory, so they then take over the care of the child. And it was noted at the first tracheostomy change that the wrong tube was inserted. She was meant to have a neonatal 3.5 uncuffed, but unfortunately she was had a pediatric tube put in, so that was rectified. And also her stay sutures weren't removed with that first tracheostomy change, which is our normal process. There was some confusion around this, and also one suture was missed and was removed the next day. So then we started hands-on involvement by her parents. So day 9, Mum started caring for her. At this stage, she was just doing suctioning, and Dad was only available on the weekends. So it was really difficult to get him to do more training. So he had minimal hands-on at that stage. On day 12, she was transferred to the ward, and there was focus on parental training and also discharge planning. So day 14, Mum removed the trachea for the first time, and the training was deemed to be going really well with her. Day 18, Mum and nursing staff started taking her off the ward for walks, and were teaching parents what equipment was needed when she was going out and about. So then we had another MDT meeting on day 20, and we were able to use a phone interpreter, not as good as face-to-face, but better than nothing. We established that the parents actually understood her condition. We explained we weren't sure how long she would require the tracheostomy tube, and we explained the importance of continuing this education, and that parents had to be competent in all areas of management before she could be discharged home. At this stage, we gave the parents their home equipment, so their suction units and their oximeter, and asked the parents to start using that on the ward so they were familiar with it before they were able to go home. We also arranged for a change table for home to make tracheostomy tube changes easier once she was home, and we ensured that she had adequate pram and car seat prior to discharge. So we set the date for about 3 weeks' time. Mum at this stage had been signed off for suctioning and tracheostomy tie changes, so we had about another 2 weeks of training before she was able to go home. And Dad at this stage had removed the trachea for the first time, and it was Mum's first insertion. So on day 24, Mum had inserted the tracheostomy tube for the second time, and all training was complete for her except for emergency management. On day 25, she was accepted onto our complex care hub program, and this program provides funding for a CNC to case manage, plus also the cost of all medical consumables, hire of medical equipment, and training and provision of support workers for respite. So when the children go home, they don't have nursing care, they have support workers who are not trained at all in medical, and we train them to do all the tracheostomy care. So it's a little bit of a different program. On day 28, Dad inserted a tube for the first time. And by day 30, Mum was independently taking Em off the ward with all the equipment and her emergency trachea bag. And on day 32, Mum had completed her emergency training. Dad unfortunately wasn't available, but Mum was now fully trained in all that care. So day 34, we had another MDT meeting, again with a telephone interpreter. And Mum voiced her fear and how she would be able to remember everything she needs to take when going out once discharged home. Parents did feel ready, however, to take her home and requested that we discharge on the weekend, so both parents would be at home as Dad wasn't able to take time off during the week. Normally, we would try and discharge on a Monday because we find weekend discharges can be a little bit difficult, but in this case, we decided to do what the parents requested. Emergency management education for both parents. Dad still required his second session, but we plan to do this once the child was discharged home on our hospital in the home program. At this stage, Dad had done his second tracheostomy change, and also we had also planned for the ENT to review her vocal cords in 12 months, so expecting her trachea tube to be in for at least 12 months at this stage. We then had a plan for her to go home on hospital in the home for 2 weeks, so we would do daily visits, and the plan was to have a medical review with telehealth after 1 week. That was help prevent the parents having to come back to the hospital, and then a face-to-face review at the end of the second week. So going home. So on day 36, we ensured all her immunisations were up to date and that the social worker had assisted in filling in all her Centrelink documents. Day 37, she had day leave, and one of our complex care nurses attended the home, and they assisted in setting up the home environment and ensured that all the consumables that were needed were available, and also attended the second emergency management session with Dad. Day 38, they had overnight leave, and the plan was, if all went well, that she wouldn't come back to the hospital. And so things did go well that night. And so she was officially discharged off the ward and transferred to the hospital in the home program by day 39. We also had a little talk about what the family goals were. Initially, she was nasogastric tube fed, and parents really didn't want her to go home with a nasogastric tube. So fortunately, we were able to transition her to fully breastfeeding prior to discharge. We also wanted to ensure she was meeting her developmental milestones, and with the help of Allied Health, she was on track prior to discharge with ongoing support in the community. Eventually, she did get our NDIS package, which is a National Disability Insurance Scheme, because she needed it for speech and in particular for language development. And in one way to overcome a language barrier in regards to ordering consumables once home, we developed a booklet with each consumable and a corresponding number. So we had a photo of the consumable and a number next to it. And then Mum could just text us and tell us what number she needed, so we knew what consumables was needed. And then we did our hospital and the home visits. And during those visits in the early days, we ensured that her emergency tracheostomy kit was complete and parents were competent in using and troubleshooting the medical equipment. We were also present for support during her first tracheostomy change. After that, the parents felt really confident that they could do that without a nurse present, so that was really good. And there was also some early difficulties with managing some stoma issues, which we sorted during those visits. And then on day 58, she was officially discharged from hospital. So in summary, parents underwent 6 weeks of extensive training for tracheostomy, including tracheostomy changes, emergency management, troubleshooting, and basic life support. These parents were supported by multiple teams throughout this process, including a complex care team, our ward staff, PICU outreach staff, allied health, and medical teams. And parents on discharge had felt competent and confident in attending to all her care needs. And luckily, she was able to be supported ongoing by a complex care team and the hospital and the home nurses in the transition to the home environment. And good news is that she got her tracheostomy decannulated about 2 months ago. So all's gone well with this family. And that's our hospital.
Okay, Hi, I'm Tracey. I'm sorry. Oh, sorry. I'm starting too soon.
Well, Tracey, let me just give a brief introduction. Thank you so much, Sandy, for walking us through that story. And one of the things that's somewhat unique about this session is that it really is going to capture, I think, a lot of personal experiences and hopefully paint a vivid picture for what it's like to walk through these transition processes. So Tracey Hurlbut is also a clinical nurse specialist who has worked at Monash Health since 1998, having previously worked at both Frankston and Alfred hospitals in intensive care in the areas of cardiothoracic and transplantation surgery. She has done a general adult ICU, critical hyperbaric nursing for 10 years and overall had 20 years of ICU experience where she'd be in the critical care at Melbourne Children's, also working in their sleep center. So she'd work with pediatric patients undergoing polysomnography or sleep studies, including both non-invasive ventilation studies as well as invasive ventilation studies that were done directly via tracheotomy, which allow for optimal gas exchange and comfort for the clients. In 2013, she joined Monash Children's home as a clinical nurse consultant and continues to work in this role. As with Sandy, her work promotes continuity of care both within and beyond the walls of the hospital. And that includes assisting, educating patients and staff to safely care for these complex children so they can live healthy, productive lives at home and in school. Tracey expresses a deep love for teaching both within and outside the hospital. And with that, I'll let Tracey do the next segment for us. We're so glad to have you, Tracey.
Thank you so much for the introduction. Okay, so Sandy's covered the ward to the home. I'm going to step back a little bit and talk about pediatric ICU to the ward with a ventilated tracheostomy. So this is a new journey for us. I'm just going to give you a little background about gorgeous Mr. A, who's up there on the photo. So Mr. A is the second son and third child. His siblings are in high school, age 16 and 17, and the family originate from Pakistan. So as with Sandy's, we do have some language issues and availability of the father for training, as he's only available on a Sunday. He is absolutely adored and one of these delicious children that you just want to eat. And his parents, however, are rather anxious for discharge, but nervous about what future care needs he's going to require. And I'll go on to the slide from here. So Mr. A is now 8 months of age, 5 months corrected. He has a history of trisomy 21, but developmentally he's progressing really well. He has some respiratory failure from chronic lung disease, but our main issue of concern that has delayed his normal transition process with our tracheostomy clients is severe multi-level and multifactorial airway obstruction due to tracheobronchomalacia. So he had a tracheostomy formation done in March 2024 for obstruction and respiratory support. But unfortunately, even on high flow, we still had repetitive respiratory tract infections as well as some consolidation. Initially, it was thought maybe to be aspiration. And so breastfeeding was ceased, much to mum's displeasure, one would say, and she was very upset regarding that. With continued issues, he had a dynamic chest CT performed in May, which showed that he had, even on high flow, left main bronchus collapse during the expiratory phase of breathing. So, however, CPAP did preserve the patency of his left main bronchus throughout the respiratory cycle, preventing collapse and gas trapping. So since continuous CPAP was implemented in May, he's had a much more stable journey. Subsequent to that, we've also lengthened the size of his tracheostomy tube, initially with upsizing to a size 4 by Vaudour, and then we further increased the internal length of the tracheostomy tube with a Flex Extend Plus tube, which is in, and we currently have custom tubes awaiting delivery for him to try and stabilise his airway. He had a past history of cardiac surgery. He's got no issues with that anymore, and some other comorbidities that don't impact on his being in hospital. Okay, so a little bit about management of the tracheostomy of Mr. A. So we've had multidisciplinary team discussions between the Royal Children's Hospital and Monash Children's Hospital teams related to where the ventilatory care of A would sit. Historically, tracheostomy ventilator clients have been transferred to the Royal Children's for continued management, as Monash Children's did not have a service established as yet. A tracheostomy working group was formed in 2016 with the aim to improve and expand pediatric tracheostomy services, and this included working towards the development of a role and appointment of a tracheostomy clinical nurse consultant at the hospital, which we're very pleased to say is hopefully going to be advertised within the next week or so. Just a little bit of perspective, there's 2 children's hospitals in Victoria, the Royal Children's and Monash Children's, and tracheostomy clients are managed at these 2 centres. A little bit of perspective about Australia. So it's estimated that our current paediatric population or children in Australia is 5.1 million of a total population of 26.5 million. If you wouldn't mind just changing slides here, please, to the map. Thank you. Okay, so just to put that in perspective, this is a photo of Australia, and our land mass is 7.688 million kilometres squared. So if we compare this to America, which has a paediatric population of 74 million to 335 million occupants in America, and your land mass is 9.83 million kilometres square metre, you can tell that we have a very sparse population, and mostly it's along our coastal areas. So we don't see as many clients as you probably do in America. We have 200 children with tracheostomies in Australia currently, and 1/3 of those are ventilated. So within Victoria, our state, which is the purple down the bottom there with the Melbourne dot, just above Tasmania, that's it, beautiful, just there, that's where we live. We have 44 children with tracheostomies, and only 11 of them are ventilated. So as you can see, just as a bit of comparison so that you get an understanding of what the difference is. Okay, so if we could move on to the next slide, thank you. So once it was determined that A would stay at Monash Children's Hospital as a client, we had to obviously accelerate the tracheostomy ventilator service so that we could deal with this. We had a collaborative approach from multiple departments to prepare appropriate documentation and troubleshooting guidelines, including emergency plans, education of both nursing and medical staff for ward readiness related to tracheostomy and ventilator care. There are a list of the multiple teams that were involved. We're extremely fortunate here to have medical, nursing and scientific staff with the expertise and willingness to facilitate this, often out of hours and in their own time, but with a smile. So it's actually been quite exciting working as a team all together. So some considerations related to A's care and why we wanted to keep him at Monash, if possible. One was family convenience and ongoing support. They'd already established a familiarisation with the hospital and staff because he'd already been here for like 6 months. Transportation was an issue. Mum does not drive, and it's an hour and a half to our hospital here at Monash, whereas travelling to the city would add extra length of time to travel. As mentioned before, they're from Pakistan, the main languages being Urdu and Hindu. So we have had some issues with interpreter availability and quality. However, we have been very fortunate that a lot of staff, both allied health, medical and nursing staff, do speak either Hindi or some Urdu, which has certainly facilitated his care needs here. Okay. So delay in transition to the ward. So as Sandy mentioned before, typically clients will spend 1 a maximum of 2 weeks within the intensive care area and then transition out to the ward for their process of going home. Young Mr. A has now been in paediatric ICU for 5 months due to not having the policy to have ventilation within our wards. His instability initially with establishing him, but also hospital policies. So as we've said, it was the instability prior to the CT, which was resolved with the increase in and CPAP ventilation, which occurred in May, and troubleshooting ventilator alarms. Initially, we had multiple obstructive alarms. So it was a process of working through how do we resolve these so that we can do a safe transition to the ward, let alone to home. So what we did in the process of resolving some of the obstructive alarms on the astral ventilation was his CPAP was increased to 6 to hopefully stabilise him. His peaking respiratory pressures we increased to 12 to allow a little bit margin for before obstructive alarms. And we commenced suctioning via the Vaudour-Marty, so there was no breach in the continuous CPAP or PEEP to support his lungs and keep them open during the expiratory phase to clear all secretions. We had a lot of moisture in the circuit, so we've taken to changing the expiratory port every 24 hours and increasing his use on a heme circuit, especially when awake and doing his activities on the mats for floor time, because he was beneath the humidifier and that was causing an increase. We've had to implement impact statements related to tracheostomy ventilation on the ward to allow for the transition from PICU to the ward. We had to change hospital policies. Development of documentation and education of nursing and medical staff related to tracheostomy ventilation and invasive versus non-invasive ventilation has had to occur, and that's progressing very nicely. So ward preparation and planning. So as we've said, it's had a lot of complex meetings up to our Director of Nursing, nurse unit managers, identifying a core group of staff who were prepared to and willing to be upskilled to look after A within a 1-to-1 initial nursing ratio on our ward. We do not have a HTU unit where A could have been transferred to, unfortunately, but everyone's come on board and are very happy to be upskilled to look after him in the care. So initially we're looking at a 1-to-1 nursing ratio on the ward with the aim to decrease that ratio as the parents become competent and we have upskilled support staff that will be following him home to look after him. And then we can reduce the ratio because the parents will not have 1-to-1 extra assistance currently at home. Staff education is required a multi-level approach, initially with forming the documentation, educating the educators who then have gone on to disseminate the education to the staff. Planned transition date was the end of July. Well, it's the 2nd of August, so how did we go? So we have started the transition to the ward. It started on the 29th of July, and he's having increasing periods of time on the ward, but currently he still goes back to PICU at night and over the weekend. So hopefully by the end of one more week, we will have staff, he will have him fully within the ward environment and transitioning towards home. So as a summary, excuse me, work in progress. So tracheostomy training with the parents is at reinforcement stage. However, it's been quite variable and inconsistent. 1 week being they're doing brilliantly, the next week being they've let go of the tracheostomy before the ties are completely tied. This very much depends on what sort of a week they've had, how fatigued they are, and ongoing issues. Parental education related to ventilation and humidification has commenced. NDIS, which is our National Disability Insurance Scheme application, was awaiting outcome. However, very pleased to announce that as of yesterday, Sandy received a phone call to say that our requests for equipment, which included 2 ventilators, a humidifier, suction unit, oximeter, and a hospital cot, and some other sundries, looks like it has been approved. So that is fantastic, and hopefully we've got a package with a lot of training hours to help support this family and training of staff in their transition to home. So complex care support worker recruitment is underway, and we will begin training now that transition has gone to the ward. We're still awaiting an executive decision whether these support workers who we can train on a hospital, in a hospital ward, will be allowed to care for him on a ward. So we've currently got a policy with legal department at the moment regarding that. Due to the bivona tracheostomy tube recall, which I'm sure you're probably all experiencing depending on what tubes you're using, we are currently rotating 2 tubes which are also part of the recalled stock, and we're just cleaning them on a weekly basis. We have ordered the custom tracheostomy tubes for him, and he will not be able to go home until he's got non-recalled tubes in situ. The father and brother will also be travelling overseas for 3 weeks soon, and we have a planned discharge home. Will not be until after they return, which very fortunately we've been able to tell the family it's more due to the fact that we're waiting on a safe discharge with tracheostomy tubes rather than we don't feel we could send mum home alone. Parents will obviously need to have completed education regarding feeding. We are now looking at replacing the nasogastric tube with a PEG tube. Sooner, he's almost 7 kilos now. Initially, the gastroenterology unit wanted to wait to 8 kilos, but he's got some erosion occurring. He's just had a scope, so they're looking at having the PEG sooner than later. So prior to going home, obviously the parents will need to have completed and be deemed competent in all of his cares. The Monash Children's at home, his staff, we've commenced education related to not assessments as yet, but to be competent so that they also are trained in his care needs related to ventilation to support him in the home environment. He's failed several attempts of his speaking valve, which is very disheartening to the family who just really want to hear his voice. So what I could say at the moment is that we see the light at the end of this journey, thanks to a fantastic collaboration of teams in this process. Thank you.
Yeah, thanks so much, Tracy. We won't unpack, all the challenges along the way right now, but I'm sure there will be many questions from our group about how you navigated many of those obstacles. What's really remarkable here is just seeing the amount of multidisciplinary collaboration and interprofessional effort of everyone working together. And some of the themes that seem really important are those around communication, that desire to hear his voice, and also some of the language difficulties that came up in Sandy's talk as well. So thank you for all the wonderful work that you've done each day and for sharing that talk with us. Now it's my pleasure to introduce Stephanie Pratt. So Stephanie is a licensed master's level social worker who is passionate about working to improve coordination of care for youth with special healthcare needs. In her role as transition program manager, she is responsible for communicating the scope of the transition to adulthood program at Children's Mercy Hospital and supporting the execution of consistent transition measures in each division. Stephanie has experienced transition professionally in the adult and pediatric hospital settings. She also personally understands its importance as the mother to a 10-year-old with cerebral palsy and a tracheostomy. Stephanie received her master's degree in social work from Loyola University in Chicago, and it's a pleasure to have her speak about transition to adulthood.
Thank you. Happy to be here. Okay, so the first thing I'm kind of going to take where Stacey and Tracy left off and kind of when the kids go home. So we have similar inpatient NICU programs or in our PICU when either children, teens, or infants receive their tracheostomy. They leave from the NICU or PICU and they do a kind of what we call a PCU, which is where the families will come up to the hospital, spend 2 days and be the sole providers of their care before they leave. And if that happens successfully, then they're ready to go. My husband and I did that for my son before he left. He was in the NICU for 8 months, and we learned all the stuff like they were talking about, how to suction, how to change his trach. And so we went through all those different stages, and then they were like, okay, go home. And it's overwhelming and scary. And we were 2 well-educated, prepared adults with a good support system, and it's still really overwhelming. And so there's a lot to kind of work through and unpack. And the other thing I'll highlight for us in the United States, we don't have a step down unit for kids with tracheostomies while they're waiting to be able to be stable to go home, while we're waiting for 2 caregivers to be able to support in the home or to have home nursing. So often those kids just remain in the hospital. Unfortunately, it's not where we want them to be, but that's kind of our reality to have a safe, consistent place for them. So now the question is, realizing that transition for us at Children's Mercy is not just at the eventual when they leave the pediatric hospital to go to adult care. With our patients with tracheostomies have transitions throughout their time with us at Children's Mercy. So our kids start out in what we call our infant home vet clinic, and it is a multidisciplinary primary care, ENT, cardiology, GI, pulmonary clinic where patients and families come once and they see all their providers that they need. It is a kind of a one-stop shop. When we left from there, we went home with a tracheostomy and a ventilator, and we came in and we were able to see everyone all at once, which was really helpful and really supportive. The clinical social workers rounded with the providers, the dietitian. So it was really just an ability to have all of that at once, and you felt really supported as a family. And so most families feel, and at least this was my experience, and a lot of them, they think, okay, I'm going to go here and then I'm going to get decannulated. My kid's going to get decannulated. I'm never going to have to go to another stage. I'm never going to have to transition somewhere else. And that's not always the purpose. I mean, we initially expected my son would get decannulated between the ages of 2 and 3. He's 10 now, and he still has his tracheostomy, doing awesome things, starting 4th grade, plays baseball, we're ready to go to the beach. So we do all the life things, but he couldn't stay in the infant home vet clinic. So then, and we do go to take him to Children's Mercy, so I can speak from experience as to what our system looks like. Then if they're not decannulated or there's no plans for decannulation, then our kids around the age of starting school, so around 5 years old, will transition to what we call the pediatric home vet clinic. And that has ENT and pulmonary, and the social workers, the dietitians, and kind of that multidisciplinary approach towards your tracheostomy and pulmonary care. But then you have to get an outside primary care at the hospital. You have to go see your cardiologist. So it's kind of a step down team that still provides that comprehensive care, but then also the caregiver and the family are kind of taking on some more of that outside care as well. And that team follows our families up until they're ready to leave the pediatric hospital. They could get decannulated at 14, 15, 16, or they could be 22 leaving the pediatric hospital still with their tracheostomy, and then they help them to transition to adult providers. So the big thing that I think is really important is transition throughout the entire hospital progression is really important. And there's multiple touch points and stages that the families go through. And sometimes there's trauma associated with each step because families never thought they were going to have to do that. And so as part of my role as the transition program manager, we support our patients and families, especially our patients and families with tracheostomies, to learn how to take care of their care and ultimately be ready to leave the pediatric hospital. So we support them by making sure teens or caregivers know what they need to know in order to care for themselves in the adult hospital. Patients and caregivers do annual readiness assessments that assesses what do you know about transition, what do you know about adult care, and then what is that young adult's anticipated level of independence. Our teams review that each year, and we provide education on the goals that they select to help them to progress toward being ready to leave the pediatric hospital and kind of our safety net that we have. And so the one thing I really want to touch on is that transition is important for all patients. We know not all patients are going to be completely independent at the time of transition, but whether you're talking to a caregiver that has provided this level of care for this patient from age 0 and now they're 22, then they still need to learn how to access this level of care in the adult setting. Because especially in the United States, it is very different. And we do not have an adult system attached to our hospital. So there's a lot of things that we need to learn. So our readiness assessments help us to do that. And we administer those based on the anticipated level of independence. So either the youth will be independent at the time of transition, the youth will need some support, or the youth is going to need full support and guardianship. And they get the appropriate assessment based off of that. And then they have appropriate goals that they get to pick from in order to be successful. And it helps us lead and support them and kind of meet them where they are and what topics they want to learn. And so one of the really big things is we have incorporated into our transition program is really making sure that we are assessing guardianship, personal care needs for these young adults when they turn 18. It's really emotional as a caregiver. I'm going to be a caregiver that's going to become a guardian when my son turns 18. But the concept of a parent having to apply for guardianship over their own child is just really stressful. And we need to make sure we're supporting our families through that. And so we start this process at the age of 16 for our families. We allow them to say, what are these decision-making and guardianship needs from my perspective as a caregiver? Does my youth have a legal guardian? Do I need community resources? Can my youth make their own healthcare decisions? Because not every youth needs guardianship, but we just want to make sure we have systems in place to support the family as they're making these steps, if that's their ultimate reality. And so, like I said, we talk about goals and education that we provide throughout a patient and family's progression through the hospital in regards to healthcare transition. So we have two different groups of transition goals that we work on. Our standard transition goals are really focused on our young adults that are going to be independent, going off to college and doing awesome things like Lou, you'll hear from in a little bit. And then we have expanded complex care goals, which really focus in on our youth with medical complexity and multiple needs and ongoing care. So our standard transition goals are, can you create a 3-sentence summary? What's your medical history and condition? What are your medications? How do alcohol, drugs, and tobacco impact your care? What's your contact information and what insurance do you have? We don't have one insurance plan for all of our patients. So everyone has something different. So they need to know. And these are things we teach all of our teams at the hospital. So think about your college age student that you're sending off into the world. They need to know these things too. And then for our complex medical care patients, we've created what we call expanded complex care goals to really focus in on school transition planning. So how does your IEP impact your tracheostomy care? How does your 18 to 21-year-old school program, how is your medical needs impacting your school services and that transition plan? Do you have access to accessible transportation? Do you need, now that you can't physically lift your child in and out of that car, do we need a wheelchair van? Do we need to have that accommodations? What kind of financial planning do we need to have in place? Medicaid waivers, supplemental security income, residential care planning. These are all things that we talk about with our families and kind of support them to ultimately be successful when they leave us. And then this is just two different ways that we provide our education. We have all of our transition education built into our medical record. And then we also have interactive patient education. So for our teens that are able to participate and engage, we want them to learn and start practicing these skills. So what is your medical condition? What's your diagnosis? What medications are you taking? What surgeries have you had? What vaccinations have you received? What allergies do you have? Where do you keep that information? So we work on different goals and we provide these resources for them to practice the skills we're teaching. And then ultimately, I know I want to make sure I have enough time, so I'll just touch on this really briefly. We feel that once they're ready to leave the pediatric hospital, we then help them transition to the adult hospital system. Within Kansas City in the United States, where we're located, there are multiple hospital systems options, and we really feel that primary care is the best entry point into that. So we transition our teens to primary care, and we allow that new primary care to work with the specialists within their hospital organization to then refer for specialty cares, so that that primary care can kind of own and lead that care. That's been kind of the best practice recommendation that we've had, and we facilitate a warm handoff of care, which includes the patient with a tracheostomy, their caregiver, their pediatric provider, and their adult care provider. So we can kind of say, this is the situation, this is the family, this is your new provider, and we can kind of provide that warm handoff, which is really successful in making families feel comfortable with the person assuming their care. And then we do a lot of community engagement. These are two events we have coming up in September. We have a resource fair for our families, and then we host a family education day on transition to adulthood.
So that was truly remarkable, Stephanie. For those, I realize that we have viewers from the US and abroad. The aspirational standard that they've achieved at Children's Mercy is something that we wish were more common. I think I can safely say that it's truly exceptional what you've built there, and there may not be another program quite like it in the country. It's really interesting because we tend to think of informed consent as a single event, and they always teach us in medical school that it's a process. In transition, also not at all a discrete event, but really a continuum that spans over the course of years with lots of surprises along the way, and sometimes steps that people didn't anticipate. So thanks for really shining a light on all the great work that you're doing, and everything that we're presenting in these talks will be available in the recorded session as well, because I know this has been a lot of information. So now for our grand finale, we have Lou Vaudour-Marty, who is a pharmacy student and marathon runner. So she is speaking to the patient perspective on this. In 2020, at the age of 16, Lou underwent tracheotomy due to severe laryngeal spasms. At the time, she shared that she thought her social, study, and personal life were over. She's going to share her journey and how she came to understand that the trach was what she needed to regain a sense of normalcy. So thanks to her family, her friends, and her partner, who she met while in the hospital a couple days after surgery, she was able to learn how to live with a close to normal life at home in between treatments. And she really speaks to how you can not only live but thrive with the tracheostomy. So today, Lou is 20 years old. She's a pharmacy and research student. She's an athlete, and she's been able to train and run a marathon alongside her studies. She's going to share that everything is not always easy. Everything is not even always possible, but there are some limitations that, though they can't be overcome, that with support, a couple of tricks, and a lot of love, dreams can be realized. So now it's my pleasure to introduce to you Lou.
Hi everyone. First of all, I would like to just add that I got my track in a very particular context, as it was during COVID lockdown, as it was in May 2020, which I feel is very privileged because we were 3 in the ICU ward because it was a non-COVID ICU ward. So I got a lot of time from the nurses and just in general the whole medical team to learn how to take care of my track and how to just get familiar with it, which I feel is not a privilege most patients do, because sadly medical providers oftentimes cannot spend 2 hours a day with a patient and just playing games and making everything feel normal again. So that was just the last thing I wanted to add to the introduction first. As I said in my presentation, it was very hard when I got the track and I thought that all my social life was over and that my friends would maybe be scared of it and that we wouldn't be able to play anymore, because I was 16 and playing is still a big part of life as a 16-year-old. But surprisingly, I mean, to my surprise at least, my friends got educated in the ENT ward a couple of months after I got my track. They learned all the emergency situations and they learned how to just act if there were anything. And we all got much more confident with, if anything happens, we all know how to react, so it's gonna be okay. And then we were finally able to play again. So we were able to play around the pool in summer, where they would just take water guns and shoot below my waistline, because I was still terrified of water at the time. I would say a very complicated thing for me at that time was being so terrified of water, because I did not get any water protection even for showering. That's not something they give to you in France in the hospital. And I had very long hair, so I was just completely terrified of water because I had to just wash them in a sink. And it's only much later that I got proper protection that I started feeling more comfortable around water, even just showering. On the 2 other pictures, you can see my friend sitting in the nursing room. I had a lot of breathing treatments in the beginning, a lot of nebulizers. It was during pollen season as well in France. I am highly allergic and I have very severe asthma. So I had to learn how to handle my asthma with now having a track, and how to deal with the new nebulized medication, because my whole treatment had to change at that time. But my friends were there that whole time. Again, they were with me in the nursing room every single time during every break, which was very nice as I was going back to high school. Although it was still during COVID, so that last year of high school, I only went to school 9 days, which made things much easier. Obviously, it would have been much different if I had to go through a normal school year right after the track, which I did not have to do. I actually had a full year to adapt to it before moving out and going on to university. During my journey of that 1 year adaptation, one of the big challenges was actually communication, because I was actually unable to talk at that time due to the laryngeal spasms, and I was getting Botox injections very often to try and paralyze the vocal cords. It was actually really complicated because I wasn't able to eat properly, I wasn't able to talk at all. But even though I was breathing fine with the track, I had a very hard time with the pain associated to the laryngeal spasms. So those surgeries were necessary, but had a huge impact. And funnily enough, things like that communication board that I made with my friend Emily, whom you saw on the first pictures, were of a tremendous help. And I feel like some things that are very easy to implement oftentimes are not, because we think they might not be that useful. But funnily enough, just having a communication board with my needs and being able to express everything I felt or needed in a very simple way was actually of a tremendous help, especially during hospitalization, to communicate with the healthcare workers and afterwards when coming back home. So after that full year of adapting, it was time to start my studies. I got my baccalaureate. I wanted to start medical school, and I had to move out, sadly, because my parents live in a very small town on the beach, which is an hour away from university, and it just wasn't possible at the time for me to drive an hour there and an hour back every single day. It wasn't possible for my parents to do the back and forth either. And the question of moving out was actually really big. Would I be able to move out and actually be in a safe space, and how could we adapt that? So the only option that was found, and that my friend and I actually loved, was for us to move in together, which we did. And we went through that whole year of medical school together to just learn how to be independent. It was very nice as a whole, because she was also learning to be independent as a young adult, and I was navigating through it with the track. She was completely educated. I mean, she had been a year prior to the track and all the needs I might have. We had a couple of emergency during that year, but everything went very safely due to the fact that she was very well educated and that I was fully trained. I do all of my cares myself, and 80% of the time I do not need any help whatsoever with anything. But then there is always that 20% of the time where I will get hospitalized, where I am a wheelchair user, when I actually cannot eat and will have a feeding tube, or when I just need help with suctioning because I have a very severe lung infection, which I do not need most of the time. So it's really trying to find a balance between me being fully independent most of the time, and then this 20% of the time actually needing to rely a lot on my friends and family. This year was my first year in the lab as a pharmacy student, and that was actually a very hard transition because surprisingly enough, it was actually one of the hardest transitions as I needed to get used to the speaking valve, which I have never tolerated and I still very much hate. Reason why I don't use a speaking valve right now. I feel very restricted when I have it, but in the lab we do manipulate very toxic products. So I had to choose between not being able to talk during the whole lab session and being able to manipulate, or not being able to manipulate and be able to talk. So that was one of the big key issues this year, was getting used to the speaking valve, wearing it more and more along the year. And I am finally relatively comfortable with it. I can use it. I choose not to most of the time. I only use it for that purpose. And the second issue is trying to handle the feeding tube, because it was the first time that I actually was in school in person, since the past 3 years was still the reminiscence of COVID. So there was a lot of online school, which was very nice to keep on adapting. This was the first in-person year, and I had to adapt to the feeds and find a schedule with university. But again, university was very understanding of my issues, and we always found ways to make it work. And then the last big thing I went through this year is the marathon training that I started a year ago. I got the okay from my doctors. It was not even an issue track-wise, because as Stephanie says, once the track is here and it becomes normal, it isn't really an issue anymore, as we've adapted through most things, and we can actually do a lot of things without having to think about it. But pneumology wise was a big issue because I have severe asthma and fibrosis. So I had to go through the training very slowly and trying to see if I would be able to go to the next step, which was always a big question mark. My first very long run was about 1.5 miles, a little over 3 kilometers, and it was huge at the time. But slowly I was able to go step by step by step by step. And then finally, I was able to actually cross the finish line of the Stockholm Marathon on the 1st of June, so exactly 2 months ago today, with my best friend Emily, who was the person who helped me the most through all of my transitions since I got the track, because she was the one finding most of those small tricks where I would be able to live a normal life. She was the one helping me make the communication board. We spent 2 nights on it before I got surgery. She was the one helping me find tricks so I would be able to carry minimal medical equipment, but still have all the necessities with me, which I am very grateful for. And it's very important for me to add that not everything is possible, because all tracheostomy patients will have different needs and limitations. I am not ventilated. I have never been ventilated, but we all have our own medical issues. The tracheostomy is hard in the sense that it might be for a laryngeal issue as much as it might be for a muscular issue, as much as it might be for a pneumology issue, which is vastly different, and is vastly different in the consequences that it has on the everyday life. And it's very important, in my opinion, to inform the patient and the family that they are able to maybe do a lot of things that they think they might not be able to do, but obviously they're not able to do everything, because it is inherently tied to the medical condition in the end. Even if I wanted to, I wouldn't be able to dive tomorrow or to run an Ironman because I am not waterproof. And even if I really wanted to, I cannot become waterproof. But despite that, time and love can go a very long way when it comes to fulfilling dreams, and in very small ways that we might not think about.
Thank you, Lou, and thank you to all of our panelists for an amazing webinar. As Michael said, there's been so much rich knowledge, wisdom, and experiences shared. So definitely a lot of rewatching of the webinar to pick up all of those golden wisdom points. In terms of the panel and questions, I would just like to spend a couple of minutes addressing some of the questions that are in the chat and some thoughts that have come up as well. I'm mindful of everyone's time and that we're over the hour, but I would really like to get the panel's opinion on a couple of parts. So in terms of questions in the chat, so I'm just going to go to those. So I might just start at the top in terms of regarding transitioning children to adult services. And in terms of, Sandy and Tracy and Stephanie, you really sort of highlighted some of that transition needed. And I guess some steps along the way. So when health systems are set up and when they're not set up and extra work is needed to be done by policy, etc. So in your experience, when is a good time to really start that transition period and how long of a lead-in do we need? So I'll open that up to the panel. So perhaps Stephanie, do you want to take that first, and then Tracy and Sandy comment on that?
So we really feel like kids, families, caregivers, young adults need at least like 3 or 4 years to really just talk about transition topics before we really start talking about where do you want to go, because there's just so many things to learn and so many things to prepare. So the recommendation that we have is to start talking about transition at the age of 15. Ideally, I would love to say we do it earlier, but just from a capacity standpoint, our standards are to start at 15. And then we start talking about options for adult providers 2 years before they leave. So our goal age of transition is 22. So we usually start talking about where do you want to go? What do you want to do around the ages of 19 or 20? Then I just saw our finances an issue or barrier for transitioning. Absolutely, especially for us, based on where we are. We're in the middle of 2 states. So half of our patients have Kansas Medicaid, half of our patients have Missouri Medicaid or commercial insurance. So that's a huge thing. We work with our patients to transition onto adult insurance plans, but finances can definitely, or access where they live, if they're in a rural community or in a metropolitan community, that impacts all those things. So those are things we just work through with our families.
Thanks. So really looking at when the goal is for that transition point and going back in terms of what's required. And I mean, stemming onto that point, and although I know Sandy and Tracy, you talked about looking at from the infant stage, going from the ICU to the wards and then to home. Talk a little bit, can you tell us just a little bit about your sort of learnings and insights in terms of the health system change as well, because you've championed a lot of change within your facility and others to support those transitions across different wards. So your learnings there, what advice would you have for people listening that don't have those systems set up? Where do you start having those conversations?
I guess one thing, Australia is a little bit different in that we have public health. So yes, you can have private insurance, but we also have public health, and we have a very good national disability scheme now too that we've been able to access. It's been a big learning process, and we've done a lot of work on supportive letters. It's not equitable throughout the system, unfortunately. It's how loud you cry and how well you present and petition for finances towards these children. However, the actual hospital service does not alter financially for the families. That's one thing. I personally haven't transitioned any through to adulthood. We did have one teenage girl, but she was extubated, and fortunately most of our children, Sandy's got the closest one who will be coming up to transition, which was
so it's saying we haven't done transition from peds to adults, but transitions usually from PICU toward to home, we always look at around 4 or 5 weeks. But this little man that Tracey was talking about is obviously a much longer one, because we had to set up a whole service.
With our non-tracheostomy clients, though, in complex clients, we do start transition, the same as Stephanie was saying, from the age of 16, start looking at setting up, because it really is very much a 2-year process of putting things and transitioning from teams from pediatric to adult. So we have got one currently that we're transitioning interstate. So luckily there's Sandy's got great contacts around Australia now, from her chatting with all the different teams, and so we're facilitating that. That's about our biggest transition, state to state.
Okay. And I mean, we heard throughout all of the talks, it was a big theme that we've got systems set up, but each person is individual in terms of their individual needs, their context, and what's going on with their life as well. So, you know, it was beautiful in terms of describing what was the week like, recognizing that fatigue and those extra, you know, elements of needing to work and families' timetables are so important to really consider. And that sort of leads me in, Lou, with your, you know, your experience and your journey that you shared with us. You described a really supportive network around you with your family and friends. And there's a question in terms of, you know, what did you find most helpful, or your top helpful things, if it's hard to pinpoint one, in terms of your transition across from teenagehood to adulthood? And was there an additional sort of tracheostomy community or any other communities that you reached out to for support as well?
So I think that the system in France is also very different from what you might have, as we really aren't great for transitions. I think that I was very lucky that it happened during COVID, because people had time, and they had time to call and arrange everything for the transition from hospital to home in the first place. But my high school also had time. They were the one actually mostly recruiting, more than the medical providers. They were the one recruiting someone so I would be able to attend class. Those 9 days that I did attend, there was we call them education specialists. Usually they help to take notes for students, or they will help with reading things. In my case, she was educated with the tracheostomy care, and she was just there sitting in the room in case anything happened. So I would say for the transition from home to, from like hospital to home and home to high school, the high school was the most helpful, but it is due to our very specific system. But then what helped me throughout the transition, surprisingly enough, was my pediatric pain management team, which I am still with them because I have refused so far to go to the adult program because I actually like them a lot, and it's very hard to change team when there is such a good feeling with the medical professionals. They are the ones who have been organizing a lot of things and just creating communications between the different doctors, because we don't have a generalized system in France. So anytime I was going to my pneumologist, I had to explain to them, oh, that happened when I was with the ENT. And when I had to go to the speech therapist, oh, and that happened when I was with the ENT and with the pneumologist. There is no direct communications, which is, I feel, really hard. And in the end, it is also mostly Facebook groups that helped. My mom actually went and sought out Facebook groups. There is a couple of French ones, but then there is the tracheostomy like warrior support group. I'm pretty sure that's how it's called. Who have a lot of insights due to the fact that you have a completely different system. There is a lot of Australians and Americans on that group, and seeing people doing things in a completely different ways has helped me find a lot of ways to feel more normal, and also understand that some processes were normal, especially like very simple things like bleeding. When you have very small amount of bleeding is very normal with a tracheotomy. It happens relatively often, not every, it's still like often occurrence. It's very scary the first time it happens, and just knowing that it happens to most people and that it's completely normal helps, and those groups help most in this sense, I would say.
Thanks for that wonderful explanation, Lou. And I want to give a little shout out to Vincia Pandian, our vice president in GTC, who is the person that runs that Facebook Trach Warriors group.
Yeah.
Offline, I've been getting a lot of really terrific feedback in addition to the chats about how inspiring your story has been to people. I also wanted to raise a question that one of the members of our community had offered, Nicole Zeitler. So she asked, do you discuss, and this question maybe for Stephanie, do you discuss supported decision-making with your families as an alternative to guardianship, since guardianship has profound impacts on an individual's ability to make key life decisions like where they would like to live in an institution or at home and otherwise?
Absolutely. I mean, 100%, we start there, and we really support our families to identify what can the young adult do, what areas of their life can they have charge in and leadership in. You know, for some of our patients, we always want to do the least restrictive decision-making model for them. Even our patients that need guardianship, we always encourage them to do supported decision-making as well, because there's always somewhere, some area of a young adult's life that they can participate in their care, in their desires. What do you love to do? Who is your family? What do you like to eat? Those types of things. So we always, we started supported decision-making and only do guardianship if it's, you know, necessary. And we have tools and pathways that we've developed for our care teams with their support, and to really help our teams identify what is the least restrictive option for our families.
Thanks so much for elaborating on that. And I'll also note that Nicole, who offered that question, she brings a tremendous amount of expertise. She's an attorney in the Department of Justice, and also has a dual life like yourself, in that she also has experiences in the home caring for a child who has needs as well. And it really speaks to the fact that although a few of us share the stage here on these panels, that there's so much expertise within our learning community, and we're so grateful for the way that enriches our conversation here. I'll also ask one other question, which is directed to Lou, that Nicole had offered. Can you explain to us why you do not like the speaking valve? My son also does not like his, but he is nonverbal, and I do not know why.
But I thought I was the only one with, I mean, a rare case was that issue, because in my ENT, like for my ENT, all the patient that he has with a trach are very well tolerating their speaking valve, and I was the odd one out. I actually would not know how to explain it properly, but if I had to try, it is mostly that I cannot control the airflow as well. And I have those filters that are from ATUS and that are usually only meant for people with laryngeal stomy. because it's not the exact same size. So I have actually an adaptator to the filter that I'm wearing right now, but it's not supposed to be wearable with a tracheotomy. I do like them much more because you cannot really see all the micro movements when I open and close all the time, but I get to decide exactly when I get air in and when I get air out through my track and through my mouth. With the speaking valve, the fact that it's always everything through the mouth just feels suffocating in a sense, and very irritating. I would not know how to describe it very well, but it's just that, yeah, that very uncomfortable feeling. So unless I have to wear it, I prefer not to, because there is no real control and it's just very tiring because of that. So I like this filter as an alternative because I do get to press on them compared to the first filters I had, which I could not obstruct the airflow. So there was a lot of air going out and it was that much harder to talk. So those are good in between, in my opinion.
Thank you, Lou, and also acknowledging the other questions that are in the Q&A and chat. We will collect all of those and make sure that we sort of reach out and give you some responses. So just to sort of close off, just to mark your calendars, there's actually a couple of things to mark on your calendars. This is one of them. So our next webinar is, our last one for the year is December the 5th, and will be on sustainability. But before December, we have our ITS, so our International Tracheostomy Symposium, that is happening online on the 1st and 2nd of November. So to find out details of that conference and to register, if you go to our website there, www.globaltrack.org, the details will be accessible there as well. So I'd just like to close and thank the panelists for their time today, for sharing their stories, for advancing our knowledge and wisdom, and also in the preparation of today. Thank you again to the community that are joining us online. It's always great to have you here and to share the knowledge. So with that, have a great day, morning or evening, wherever you are in the world.